A patient is in front of you, gasping for air, chest heaving, and struggling to draw a single breath. You have seconds to act before they lose consciousness. We are going to build the exact step-by-step priority stack you need to manage a respiratory crisis and prevent complete ventilatory failure. Whether the underlying trigger is an acute asthma attack or a COPD exacerbation, your universal starting point is always the same: airway, breathing, and circulation. Knowing what interventions to use isn't enough. Executing them in the precise order is the difference between saving a patient's airway and losing it entirely. Step 1 is purely mechanical. When a patient is dyspneic, the very first action you take is getting them out of a flat, supine position. This diagram shows exactly why. On the left, lying flat physically compresses the lungs. Sitting upright in a high Fowler's position, between 60 and 90 degrees, allows gravity to drop the diaphragm, giving the lungs maximum room to expand. If the distress is severe, you shift them into the tripod position. Leaning forward and bracing the arms on the knees or a table maximizes their ability to use accessory muscles in the neck and shoulders to pull air in. Once their mechanics are optimized, your second priority is securing safe and adequate oxygenation. For an acute asthma attack, the protocol is aggressive. You administer immediate, high-flow oxygen without restriction to flood the system. But COPD requires a highly controlled approach. This nursing care text lays out the strict parameters. Oxygen levels for a COPD patient must be maintained between 88 and 92%. The text right above that highlights the specific danger. In COPD, chronically low arterial levels of oxygen serve as the primary drive for breathing. If you flood them with high-flow oxygen, you knock out that drive, and their breathing will effectively stop. Immediate upright positioning, paired with these disease-specific oxygen parameters, builds a vital bridge. It keeps your patient stable until your medications take effect. With the patient stabilized, the rule for pharmacology is strict sequencing, fast before slow. This graphic breaks the sequence down. Your absolute first-line rescue medication is albuterol, a short-acting beta agonist. Albuterol is engineered to force the smooth muscles around the airways to relax. It rapidly expands a constricted airway so air can move again. Only after the airway is open do you move to step 2, slow-acting corticosteroids, like fluticasone. Because the passage is now wide open, these steroid particles can travel deep into the lungs to treat the underlying inflammation. To execute this correctly, you must wait 1 full minute between the albuterol and the steroid administration. Afterwards, ensure the patient rinses their mouth to prevent fungal thrush. Finally, we reach leukotriene antagonists like montelukast. As indicated here, this is strictly a maintenance drug used for long-term prevention, never for an active emergency. This is the sequencing trap. If you administer a steroid while the bronchioles are still constricted, the medication cannot reach the target tissue. Albuterol must physically dilate the pathway first, or the subsequent treatment remains blocked in the upper airway. With medications administered, you shift into evaluation, re-auscultate lung sounds, and check vital signs to verify your interventions are working. Look closely at this nursing actions guide for albuterol. Tachycardia and tremors are listed right here as expected adverse effects. A fast heart rate means the drug is in their system, not necessarily that the patient is crashing. A successful intervention means you will hear a clear transition. The loud, strained wheezing will gradually give way to quieter, easier respiratory effort. But here is the major warning sign. If a patient is wheezing loudly and those breath sounds abruptly stop while they are still working hard to breathe, you have a silent chest. This textbook excerpt defines exactly what that means. This is status asthmaticus. The airway hasn't cleared, it has entirely clamped down, and airflow has completely stopped. You must trigger your emergency escalation protocol immediately. As outlined here, you prepare for emergency intubation, administer IV fluids and continuous bronchodilators, and initiate systemic steroid therapy. The sudden absence of wheezing in a struggling patient is never a sign of recovery. It is the loudest alarm that ventilatory failure is imminent. Let's recap the completed priority stack. Position them upright. Secure their oxygenation based on their specific disease. Open the airway with albuterol first, and follow up with slow-acting steroids. Applying this exact sequence takes the chaos out of a respiratory crisis. You move from a panicked reaction to a strategic, life-saving clinical process. By mastering these steps, you are ready to walk into a room and handle an airway emergency with calm, precise action. To complete your mastery of respiratory interventions, you need to understand the lab values behind them. Click over to our next video on ABG interpretation to keep building your clinical confidence.